Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Aficamten for symptomatic obstructive hypertrophic cardiomyopathy. Background. One of the major determinants of exercise intolerance and limiting symptoms among patients with obstructive hypertrophic cardiomyopathy, HCM, is an elevated intracardiac pressure resulting from left ventricular outflow tract obstruction. Aficamten is an oral selective cardiac myosin inhibitor that reduces left ventricular outflow tract gradients by mitigating cardiac hypercontractility. Methods. In this Phase 3, double-blind trial, we randomly assigned adults with symptomatic obstructive HCM to receive Aficamten. Starting dose, 5 mg, maximum dose, 20 mg, or placebo for 24 weeks, with dose adjustment based on echocardiography results. The primary endpoint was the change from baseline to week 24 in the peak oxygen uptake, as assessed by cardiopulmonary exercise testing. The 10 pre-specified secondary endpoints, tested hierarchically, were change in the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score, KCCQ, CSS, improvement in the New York Heart Association, NYHA, functional class, change in the pressure gradient after the Valsalva maneuver, occurrence of a gradient of less than 30 mm Hg after the Valsalva maneuver, and duration of eligibility for septal reduction therapy, all assessed at week 24, change in the KCCQ CSS, improvement in the NYHA functional class, change in the pressure gradient after the Valsalva maneuver, and occurrence of a gradient of less than 30 mm Hg after the Valsalva maneuver, all assessed at week 12, and change in the total workload as assessed by cardiopulmonary exercise testing at week 24. Results. A total of 282 patients underwent randomization, 142 to the Aficamten group, and 140 to the placebo group. The mean age was 59.1 years, 59.2% were men. The baseline mean resting left ventricular outflow tract gradient was 55.1 mm Hg, and the baseline mean left ventricular ejection fraction was 74.8%. At 24 weeks, the mean change in the peak oxygen uptake was 1.8 ml per kilogram per minute, 95% confidence interval, CI, 1.2 to 2.3, in the Aficamten group, and 0.0 ml per kilogram per minute, 95% CI, minus 0.5 to 0.5, in the placebo group. Least squares mean between group difference, 1.7 ml per kilogram per minute, 95% CI, 1.0 to 2.4, p less than 0.001. The results for all 10 secondary endpoints were significantly improved with Aficamten as compared with placebo. The incidence of adverse events appeared to be similar in the two groups. Conclusions. Among patients with symptomatic obstructive HCM, treatment with Aficamten resulted in a significantly greater improvement in peak oxygen uptake than placebo. Intensive ambulance delivered blood pressure reduction in hyperacute stroke. Background. Treatment of acute stroke, before a distinction can be made between ischemic and hemorrhagic types, is challenging. Whether very early blood pressure control in the ambulance improves outcomes among patients with undifferentiated acute stroke is uncertain. Methods. We randomly assigned patients with suspected acute stroke that caused a motor deficit and with elevated systolic blood pressure, greater than or equal to 150 Hg, who were assessed in the ambulance within 2 hours after the onset of symptoms, to receive immediate treatment to lower the systolic blood pressure. Target range, 130 to 140 mm Hg, intervention group, or usual blood pressure management, usual care group. The primary efficacy outcome was functional status as assessed by the score on the modified Rankin scale, range 0, no symptoms, to 6, death, at 90 days after randomization. The primary safety outcome was any serious adverse event. Results. A total of 2,404 patients, mean age, 70 years, in China underwent randomization and provided consent for the trial, 1,205 in the intervention group, and 1,199 in the usual care group. The median time between symptom onset and randomization was 61 minutes. Interquartile range, 41 to 93, and the mean blood pressure at randomization was 178/98 of a millimeter Hg. Stroke was subsequently confirmed by imaging in 2,240 patients, of whom 1,041, 46.5%, had a hemorrhagic stroke. At the time of patient's arrival at the hospital, the mean systolic blood pressure in the intervention group was 159 mm Hg, as compared with 170 mm Hg in the usual care group. Overall, there was no difference in functional outcome between the two groups. Common odds ratio, 1.00. 95% confidence interval, CI, 0.87 to 1.15. And the incidence of serious adverse events was similar in the two groups. Pre-hospital reduction of blood pressure was associated with a decrease in the odds of a poor functional outcome among patients with hemorrhagic stroke. Common odds ratio, 0.75, 95% CI, 0.60 to 0.92, but an increase among patients with cerebral ischemia, common odds ratio, 1.30, 95% CI, 1.06 to 1.60. Conclusions. In this trial, pre-hospital blood pressure reduction did not improve functional outcomes in a cohort of patients with undifferentiated acute stroke, of whom 46.5% subsequently received a diagnosis of hemorrhagic stroke. Next, we will be discussing articles from Journal of American Medical Association. Aspirin versus Placebo, as adjuvant therapy for breast cancer, the Alliance A01-1502, randomized trial. Importance: observational studies of survivors of breast cancer and prospective trials of aspirin for cardiovascular disease suggest improved breast cancer survival among aspirin users, but prospective studies of aspirin to prevent breast cancer recurrence are lacking. Objective: to determine whether aspirin decreases the risk of invasive cancer events among survivors of breast cancer. Design, setting, and participants. A011502, a Phase 3, randomized, placebo-controlled, double-blind trial conducted in the United States and Canada, with 3,020 participants who had high-risk non-metastatic breast cancer. Enrolled participants from 534 sites from January 6, 2017, through December 4, 2020, with follow-up to March 4, 2023. Interventions: participants were randomized, stratified for hormone receptor status, positive versus negative, body mass index, less than or equal to 30 versus greater than 30, stage 2 versus 3, and time since diagnosis, less than 18 versus greater than or equal to 18 months, to receive 300 mg of aspirin, N equals 1,510, or placebo once daily, N equals 1,510, for 5 years. Main outcomes and measures. The primary outcome was invasive disease-free survival. Overall survival was a key secondary outcome. Results: a total of 3,020 participants were randomized when the Data and Safety Monitoring Committee recommended suspending the study at the first interim analysis because the hazard ratio had crossed the pre-specified futility bound by median follow-up of 33.8 months. Range: 0.1 to 72.6 months. 253 invasive disease-free survival events were observed, 141 in the aspirin group and 112 in the placebo group, yielding a hazard ratio of 1.27, 95% CI, 0.99 to 1.63, p equals 0.06. All invasive disease-free survival events, including death, invasive progression, both distant and locoregional, and new primary events, were numerically higher in the aspirin group, although the differences were not statistically significant. There was no difference in overall survival, hazard ratio, 1.19, 95% CI, 0.82 to 1.72. Rates of grades 3 and 4 adverse events were similar in both groups. Conclusion and relevance. Among participants with high-risk non-metastatic breast cancer, daily aspirin therapy did not improve risk of breast cancer recurrence or survival in early follow-up. Despite its promise and wide availability, aspirin should not be recommended as an adjuvant breast cancer treatment. Smoking cessation after initial treatment failure with Varenicline or nicotine ReplacementA, randomized clinical trial. Importance. Most people who smoke do not quit on their initial attempt. Objective. To determine the best subsequent strategy for non-abstinence following initial treatment with Varenicline or combined nicotine replacement therapy, CancerThe. Design, setting, and participants using a double-blind, placebo-controlled, sequential multiple assignment randomized trial. 490 volunteers were randomized to receive 6 weeks of Varenicline or CancerThe. After 6 weeks, non-abstainers were re-randomized to continue, switch, or increase medication dosage for 6 additional weeks. Results. The 490 randomized participants, 210 female, 43%, 287 non-Hispanic white, 58%, mean age, 48.1 years, smoked an average of 20 cigarettes per day. After the first phase, 54 participants in the CancerThe group were abstinent and continued their therapy. Of the 191 who were not abstinent, 151 were re-randomized, and the 40 who did not return for re-randomization were assigned to continue their initial CancerThe condition in Phase 2. The end-of-treatment abstinence rate for the 191 Phase 1 non-abstainers was 8%, 95% credible interval, CRI, 6% to 10%. For the 90, 47%, who continued at the dosage condition, 14%, CRI, 10% to 18%. For the 50, 33%, who increased their dosage, and 14%, 95% CRI, 10% to 18%. For the 51, 34%, who switched to Varenicline, absolute risk difference, RD, 6%, 95% CRI, 6% to 11%, with more than 99% posterior probability that either strategy conferred benefit over continuing the initial dosage. After the first phase, 88 participants in the Varenicline group were abstinent and continued their therapy. Of the 157 who were not abstinent, 122 were re-randomized, and 35 who did not return for re-randomization were assigned to continue with the Varenicline condition. The end-of-treatment abstinence rate for the 157 Phase 1 non-abstainers was 20%, 95% CRI, 16% to 26%, for the 39, 32%, who increased their Varenicline dosage, 0, 95% CRI, 0 to 0, for the 41, 34%, who switched CancerThe, and 3%, 95% CRI, 1% to 4%, for the 77, 49%, who were assigned to the continued Varenicline condition, absolute RD, -3%, 95% CRI, -4% to -1%, with more than 99% posterior probability that continuing Varenicline at the initial dosage was worse than switching to a higher dosage. Conclusions and relevance. For individuals who smoked but did not achieve abstinence after treatment with Varenicline, increasing the dosage enhanced abstinence versus continuing, whereas for non-abstainers initially treated with CancerThe, a dosage increase or switch to Varenicline enhanced abstinence and may be viable rescue strategies. Next, we will be discussing articles from Annals of Internal Medicine. Efficacy of voluntary medical male circumcision to prevent HIV infection among men who have sex with men. Background. Observational studies suggest that voluntary medical male circumcision, VMMC, may lower HIV risk among men who have sex with men, MSM. A randomized controlled trial, RCT, is needed to confirm this. Objective. To assess the efficacy of VMMC, in preventing incident HIV infection among MSM. Design. An RCT with up to 12 months of follow-up. Chinese Clinical Trial Registry. Chictor 2, 000-39436 setting. 8 cities in China. Participants. Uncircumcised, HIV, seronegative men aged 18 to 49 years, who self-reported predominantly practicing insertive anal intercourse and had 2 or more male sex partners in the past 6 months. Intervention. VMMC. Measurements. Rapid testing for HIV was done at baseline and at 3, 6, 9, and 12 months. Behavioral questionnaires and other tests for sexually transmitted infections were done at baseline, 6 months, and 12 months. The primary outcome was HIV seroconversion using an intention to treat analysis. Results. The study enrolled 124 men in the intervention group and 123 in the control group, who contributed 120.7 and 123.1 person-years of observation, respectively. There were 0 seroconversions in the intervention group, 0 infections, 95% CI, 0.0 to 3.1 infections per 100 person-years, and 5 seroconversions in the control group, 4.1 infections, CI, 1.3 to 9.5 infections per 100 person-years. The HIV hazard ratio was 0.09, CI, 0.00 to 0.81, P equals 0.029, and the HIV incidence was lower in the intervention group, log rank P equals 0.025. The incidence rates of syphilis, herpes simplex virus type 2, and penile human papillomavirus were not statistically significantly different between the 2 groups. There was no evidence of HIV risk compensation. Limitation. Few HIV seroconversions and limited follow-up period. Conclusion. Among MSM who predominantly practice insertive anal intercourse, VMMC is efficacious in preventing incident HIV infection. MSM should be included in VMMC guidelines. Benefits and risks associated with statin therapy for primary prevention in old and very old adults. Background. There is little consensus on using statins for primary prevention of cardiovascular diseases, CVDs, and all-cause mortality in adults aged 75 years or older, due to the underrepresentation of this population in randomized controlled trials. Objective. To investigate the benefits and risks of using statins for primary prevention in old, aged 75 to 84 years, and very old, aged greater than or equal to 85 years, adults. Design. Sequential target trial emulation, comparing matched cohorts initiating versus not initiating statin therapy. Setting. Territory-wide public electronic medical records in Hong Kong. Participants. Persons aged 75 years or older, who met indications for statin initiation from January 2008 to December 2015, were included. Participants with pre-existing diagnosed CVDs at baseline, such as coronary heart disease, CHD, were excluded from the analysis. Among 69,981 eligible persons, aged 75 to 84 years, and 14,555 persons, aged 85 years or older, 41,884 and 9,457 had history of CHD equivalents, for example, diabetes, in the respective age groups. Intervention. Initiation of statin therapy. Measurements. Incidence of major CVDs, stroke, myocardial infarction, or heart failure, all-cause mortality, and major adverse events, myopathies, and liver dysfunction. Results. Of 42,680 matched person trials, aged 75 to 84 years, and 5,390 matched person trials, aged 85 years or older, average follow-up, 5.3 years, 9,676, and 1,600 of them developed CVDs in each age group, respectively. Risk reduction for overall CVD incidence was found for initiating statin therapy in adults, aged 75 to 84 years. 5-year standardized risk reduction, 1.20%, 95% CI, 0.57% to 1.82%. In the intention to treat, ITT analysis 5.00%, CI 1.11% to 8.89%. In the per protocol PP analysis, and in those aged 85 years or older, ITT 4.4%, CI 1.40% to 7.48%, PP 12.50%, CI 4.33% to 20.66%. No significantly increased risks for myopathies and liver dysfunction were found in both age groups. Limitation. Unmeasured confounders, such as lifestyle factors of diet and physical activity, may exist. Conclusion. Reduction for CVDs after statin therapy were seen in patients aged 75 years or older, without increasing risks for severe adverse effects. Of note, the benefits and safety of statin therapy were consistently found in adults aged 85 years or older. Next, we will be discussing articles from British Medical Journal. Tislelizumab plus chemotherapy versus placebo plus chemotherapy as first-line treatment for advanced gastric or gastro-oesophageal junction adenocarcinoma. Objective: to evaluate the efficacy and safety of tislelizumab added to chemotherapy as first-line, primary treatment for advanced gastric or gastro-oesophageal junction adenocarcinoma, compared with placebo plus chemotherapy. Design randomized, double-blind, placebo-controlled, phase 3 study, setting 146 medical centers across Asia, Europe, and North America, between December 13, 2018, and February 28, 2023. Participants, 1,657 patients, aged greater than or equal to 18 years with human epidermal growth factor, receptor 2 negative, locally advanced unresectable or metastatic gastric or gastro-esophageal junction adenocarcinoma, regardless of programmed death, ligand 1, PD-L1, expression status, who had not received systemic anti-cancer therapy for advanced disease. Interventions patients were randomly, 1-to-1, assigned to receive either tislelizumab 200 mg or placebo intravenously every 3 weeks in combination with chemotherapy, investigator's choice of oxaliplatin and capecitabine, or cisplatin and 5-fluorouracil, and stratified by region, PD-L1 expression, presence or absence of peritoneal metastases, and investigator's choice of chemotherapy. Treatment continued until disease progression or unacceptable toxicity. Main outcome measures. The primary endpoint was overall survival, both in patients with a PD-L1 tumor area positivity, TAP, score of greater than or equal to 5%, and in all randomized patients. Safety was assessed in all those who received at least one dose of study treatment. Results of 1,657 patients screened between December 13, 2018, and February 9, 2021. 660 were ineligible due to not meeting the eligibility criteria, withdrawal of consent, adverse events, or other reasons. Overall, 997 were randomly assigned to receive tislelizumab plus chemotherapy, N equals 501, or placebo plus chemotherapy, N equals 496. Tislelizumab plus chemotherapy showed statistically significant improvements in overall survival versus placebo plus chemotherapy. In patients with a PD-L1 TAP score of greater than or equal to 5%, median 17.2 months v 12.6 months, hazard ratio 0.74, 95% confidence interval 0.59 to 0.94, p equals 0.006, interim analysis, and in all randomized patients, median 15.0 months v 12.9 months, hazard ratio 0.80, 0.70 to 0.92, p equals 0.001, final analysis. Grade 3 or worse treatment-related adverse events were observed in 54%, 498, of patients in the tislelizumab plus chemotherapy arm versus 50%, 494, in the placebo plus chemotherapy arm. Conclusions: tislelizumab added to chemotherapy. Primary treatment for advanced or metastatic gastric or gastro-esophageal junction adenocarcinoma provided superior overall survival with a manageable safety profile versus placebo plus chemotherapy in patients with a PD-L1 TAP score of greater than or equal to 5%, and in all randomized patients. Epidural analgesia during labor and severe maternal morbidity. Objectives: to determine the effect of labor epidural on severe maternal morbidity, SMM, and to explore whether this effect might be greater in women with a medical indication for epidural analgesia during labor, or with preterm labor. Design population-based study. Setting all NHS hospitals in Scotland. Participants 567, 216 women in labor. At 24, plus 0 to 42, plus 6 weeks gestation between January 1, 2007, and December 31, 2019, delivering vaginally or through unplanned cesarean section. Main outcome measures. The primary outcome was SMM, defined as the presence of greater than or equal to one of 21 conditions used by the U.S. Centers for Disease Control and Prevention, CDC, as criteria for SMM, or a critical care admission, with either occurring at any point from date of delivery to 42 days postpartum, described as SMM. Secondary outcomes included a composite of greater than or equal to one of the 21 CDC conditions, and critical care admission, SMM, plus critical care admission, and respiratory morbidity. Results of the 567, 216 women, 125,024, 22.0%, had epidural analgesia during labor. SMM occurred in 2,412 women, 4.3 per 1,000 births, 95% confidence interval, CI, 4.1 to 4.4. Epidural analgesia was associated with a reduction in SMM, adjusted relative risk, 0.65, 95%, CI 0.50 to 0.85. SMM plus critical care admission, 0.46, 0.29 to 0.73, and respiratory morbidity, 0.42, 0.16 to 1.15, although the last of these was underpowered and had wide confidence intervals. Greater risk reductions in SMM were detected among women with a medical indication for epidural analgesia, 0.50, 0.34 to 0.72, compared with those with no such indication, 0.67, 0.43 to 1.03, p less than 0.001 for difference. More marked reductions in SMM were seen in women delivering preterm, 0.53, 0.37 to 0.76, compared with those delivering at term or post-term, 1.09, 0.98 to 1.21, p less than 0.001 for difference. The observed reduced risk of SMM with epidural analgesia was increasingly noticeable as gestational age at birth decreased in the whole cohort and in women with a medical indication for epidural analgesia. Conclusion: epidural analgesia during labor was associated with a 35% reduction in SMM and showed a more pronounced effect in women with medical indications for epidural analgesia and with preterm births. Expanding access to epidural analgesia for all women during labor, and particularly for those at greatest risk, could improve maternal. Next, we will be discussing articles from Journal of Clinical Oncology. Impact of Helicobacter pylori infection and treatment on colorectal cancer in a large, nationwide cohort. Purpose: Helicobacter pylori is the most common cause of infection-associated cancer worldwide. We aimed to evaluate the impact of H. pylori infection and treatment on colorectal cancer, CRC, incidence and mortality. Patients: U.S. veterans who completed H. pylori testing between 1999 and 2018. Methods: we conducted a retrospective cohort analysis among adults within the Veterans Health Administration who completed testing for H. pylori. The primary exposures were 1. H. pylori test result, positive/negative, and 2. H. pylori treatment, untreated/treated, among H. pylori positive individuals. The primary outcomes were CRC incidence and mortality. Follow-up started at the first H. pylori testing and continued until the earliest of incident or fatal CRC, non-CRC death, or December 31, 2019. Results. Among 812,736 individuals tested for H. pylori, 205,178, 25.2%, tested positive. Being H. pylori positive versus H. pylori negative was associated with higher CRC incidence and mortality. H. pylori treatment versus no treatment was associated with lower CRC incidence and mortality. Absolute risk reduction 0.23% to 0.35% through 15-year follow-up. Being H. pylori positive versus H. pylori negative was associated with an 18% adjusted hazard ratio, adjusted HR, 1.18, 95% CI, 1.12 to 1.24, and 12% adjusted HR, 1.12, 95% CI, 1.03 to 1.21, higher incident and fatal CRC risk, respectively. Individuals with untreated versus treated H. pylori infection had 23% adjusted HR, 1.23, 95% CI, 1.13 to 1.34, and 40% adjusted HR, 1.40, 95% CI, 1.24 to 1.58, higher incident and fatal CRC risk, respectively. The results were more pronounced in the analysis restricted to individuals with non-serologic testing. Conclusion. H. pylori positivity may be associated with small but statistically significant, higher CRC incidence and mortality. Untreated individuals, especially those with confirmed active infection, appear to be most at risk. Next, we will be discussing articles from Journal of Hepatology. Primary hypocholesterolemia is associated with an increased risk of hepatic complications in the general population. Background and aims. Beyond cardiovascular disease protection, the health consequences of very low concentrations of low-density lipoprotein cholesterol, LDL-C, remain a matter of debate. In primary hypobetalipoproteinemia, HBL, liver steatosis and cirrhosis have occasionally been reported. Here, we aimed to investigate the association between HBL and the risk of hepatic complications, cirrhosis complications, and/or primary liver cancer in the general population. Methods. A cohort study was conducted in the French population-based cohort Constances. Participants with primary HBL, LDL, C less than 5th percentile for age and sex, HBL, were compared with those with normal LDL-C concentrations, 40th 60th percentile, control. Participants on lipid-lowering therapies were excluded. For hepatic complications, follow-up events were compared by calculating the incidence density ratio, IDR. The same analyses were replicated in the UK Biobank, UKBB, cohort. Results. In the Constances and UKBB cohorts, 34,653 and 94,666 patients were analyzed. With median ages of 45 and 56 years, mean LDL-C concentrations, HBL versus control, of 71 versus 128 mg/dl, and 86 versus 142 mg/dl, and mean follow-up durations of 5.0 and 11.5 years, respectively. The HBL group presented a higher incidence of hepatic complications than the control group, 0.32 versus 0.07 over 1,000 person-years. IDR equals 4.50, 95% CI, 1.91 to 10.6, in Constances, and 0.69 versus 0.21 1,000th person-years. IDR equals 3.27, 95%, CI 2.63 to 4.06, in the UKBB. This risk proved to be independent of classic risk factors for liver disease, obesity, alcohol consumption, diabetes, viral hepatitis, including in a 5-year landmark analysis, excluding early events. Sensitivity analyses based on apoprotein B levels, instead of LDL-C levels, or genetically defined HBL, showed similar results. Conclusions. HBL is associated with a markedly increased risk of hepatic complications. HBL must be considered as a substantial independent risk factor for liver diseases, which justifies specific prevention and screening. Next, we will be discussing articles from Clinical Gastroenterology. Validated clinical score to predict gastro-oesophageal reflux in patients with chronic laryngeal symptoms, Couge reflux. Background and aims. Discerning whether laryngeal symptoms result from gastro-oesophageal reflux is clinically challenging, and a reliable tool to stratify patients is needed. We aimed to develop and validate a model to predict the likelihood of gastro-oesophageal reflux disease, GERD, among patients with chronic laryngeal symptoms. Methods. This multi-center international study collected data from adults with chronic laryngeal symptoms who underwent objective testing, upper gastrointestinal endoscopy, and/or ambulatory reflux monitoring between March 2018 and May 2023. The training phase identified a model with optimal receiver operating characteristic curves, and beta coefficients informed a weighted model. The validation phase assessed performance characteristics of the weighted model. Results. A total of 856 adults, 304 in the training cohort, and 552 in the validation cohort, were included. In the training phase, the optimal predictive model, area under the curve, 0.68, 95% CI, 0.62 to 0.74, was the cough, overweight/obesity, globus, hiatal hernia, regurgitation, and male sex, Couge reflux, score, with a lower threshold of 2.5 and an upper threshold of 5.0 to predict proven GERD. In the validation phase, the CO reflux score had an area under the curve of 0.67, 95% CI, 0.62 to 0.71, with 79% sensitivity and 81% specificity for proven GERD. Conclusions. The externally validated Couge reflux score is a clinically practical model to predict the likelihood of proven GERD. The score classifies most patients with chronic laryngeal symptoms as low/high likelihood of proven GERD, with only 38% remaining as indeterminate. Thus, the Couge reflux score can guide diagnostic strategies and reduce inappropriate proton pump inhibitor use or testing for patients referred for evaluation of chronic laryngeal symptoms. Hypercholesterolemia is associated with dysregulation of lipid metabolism and poor prognosis in primary biliary cholangitis. Background and aims. Hypercholesterolemia is frequently diagnosed in patients with primary biliary cholangitis, PBC. However, its association with the prognosis and lipid metabolism is unknown. In this study, we aimed to investigate the prognostic value of baseline total cholesterol, TC, levels in PBC, and characterized the associated lipid metabolism. Methods. 531 patients with PBC without prior cirrhosis-related complications were randomly divided into the derivation and validation cohorts at a ratio of 7:3. Complete clinical data were obtained and analyzed. The endpoints were defined as liver-related death, liver transplantation, and cirrhosis-related complications. Lipidomics was performed in 89 patients and 28 healthy controls. Results. Baseline TC was independently associated with poor liver-related outcomes, and adjusted C statistics were 0.80, 95% confidence interval, CI, 0.74 to 0.85, and 0.88, 95%, CI, 0.78 to 0.91, in the derivation and validation cohorts, respectively. The predictive ability of TC for disease outcomes was stable over time and comparable with the GLOBE score. The 200 mg/dl cutoff optimally divided patients into low and high TC groups. A combination of TC and GLOBE score provided a more accurate stratification of patients into risk subgroups. Lipidomics indicated an upregulation of lipid families in high TC patients. Pathway analysis of 66 upregulated lipids revealed the dysregulation of glycerophospholipid and sphingolipid metabolism in high TC patients, which were associated with poor liver-related outcomes. Conclusions. Our results indicate that patients with PBC having baseline TC levels above 200 mg/dl have unique lipidome characteristics and are at a higher risk of poor liver-related outcomes. Next, we will be discussing articles from Journal of Clinical Rheumatology. Choroidal thickness is a biomarker associated with response to treatment in ankylosing spondylitis. Objective. Choroidal thickness, CT, has been evaluated as a marker of systemic inflammation in ankylosing spondylitis, AS. This study evaluates the CT of AS patients before and after 6 months of biological treatment. Methods. This longitudinal multi-center study evaluated CT in 44 AS patients. The correlations between CT and C-reactive protein, CRP, with disease activity indices were calculated. The concordance between CT and CRP was determined. We assessed factors associated with response to treatment. Clinically important improvement was defined as a decrease in ankylosing spondylitis disease activity score of 1.1 points or greater. Results. 44 eyes in patients aged 18 to 65 years were included. Mean CT values were significantly higher at baseline than after 6 months of treatment. Baseline, 355 PAS. 28 plus or minus 80.46 m, 6 months, 341.26 plus or minus 81.06 m, p less than 0.001. There was a 95% concordance between CT and CRP at baseline and 6 months. Clinically important improvement was associated with lower baseline CT and age as independent factors. Odds ratios, 0.97, 95% confidence interval, 0.91 to 0.93, p equals 0.009, and 0.81, 95% confidence interval, 0.7 to 0.95, p equals 0.005. With baseline CT of less than 374 m, sensitivity 78%, specificity 78%, area under the curve 0.70, likelihood ratio 3.6. Conclusions. Choroidal thickness decreased significantly after 6 months of biological treatment in all treatment groups. Choroidal thickness and CRP had a 95% concordance. A high CT was associated with a risk of biological treatment failure. Choroidal thickness can be considered a useful biomarker of inflammation and a factor associated with response to treatment in AS. Next, we will be discussing articles from Arthritis and Rheumatology. Effect of recent anti-rheumatic drug on features of rheumatoid arthritis-associated lymphoproliferative disorders. Objective. In this study, we examine how advancements in novel anti-rheumatic drugs affect the clinicopathologic features of lymphoproliferative disorder, LPD, in patients with rheumatoid arthritis, RA. Methods. In this multi-center study across 53 hospitals in Japan, we characterized patients with RA who developed LPDs and visited the hospitals between January 1999 and March 2021. The statistical tools used included Fisher's exact test, the Mann-Whitney U-test, the log-rank test, logistic regression analysis, and Cox proportional hazards models. Results. Overall, 752 patients with RA-associated LPD, RA-LPD, and 770 with sporadic LPD were included in the study. We observed significant differences in the clinicopathologic features between patients with RA-LPD and those with sporadic LPD. Histopathological analysis revealed a high frequency of LPD-associated immunosuppressive conditions. Furthermore, patients with RA-LPD were evaluated based on the anti-rheumatic drugs administered. The methotrexate, MTX, plus tacrolimus, and MTX plus tumor necrosis factor inhibitor, TNF, groups had different affected site frequencies and histologic subtypes than the MTX-only group. Moreover, MTX and TNF may synergistically affect susceptibility to Epstein-Barr virus infection. In case of anti-rheumatic drugs administered after LPD onset, Tislelizumab, TCZ-only therapy was associated with lower frequency of regrowth after spontaneous regression than other regimens. Conclusion: anti-rheumatic drugs administered before LPD onset may influence the clinicopathologic features of RA-LPD, with patterns changing over time. Furthermore, TCZ-only regimens are recommended after LPD onset. Next, we will be discussing articles from Circulation. Comparison of incidence and prognostic impact of ischemic, major bleeding and heart failure events in patients with chronic coronary syndrome. Insights from the Corona Registry. Background: evaluation of the residual risk in patients with chronic coronary syndrome is challenging in daily practice. Several types of events, myocardial infarction, ischemic stroke, bleeding, and heart failure, HF, may occur, and their impact on subsequent mortality is unclear in the era of modern evidence-based pharmacotherapy. Methods: coroner, suivi d'une cohorte de patients coronariens stables, en région Nord-Pas-de-Calais, is a prospective multicenter cohort that enrolled 4,184 consecutive unselected outpatients with chronic coronary syndrome. We analyzed the incidence, correlates, and impact of ischemic events, a composite of myocardial infarction and ischemic stroke, major bleeding, bleeding academic research consortium 3 or higher, and hospitalization for HF, on subsequent patient mortality. Results: during follow-up, median, 4.9 years, 677 patients, 16.5%, died. The 5-year cumulative incidences, death as competing event, of ischemic events, major bleeding, and HF hospitalization were 6.3%, 5.6% to 7.1%, 3.1%, 2.5% to 3.6%, and 8.1%, 7.3% to 9%, respectively. Ischemic events, major bleeding, and HF hospitalization were each associated with all-cause mortality. Major bleeding and hospitalization for HF were associated with the highest mortality rates in the post-event period, 42.4%/Y and 34.7%/Y, respectively, compared with incident ischemic events, 13.1%/Y. The age and sex-adjusted hazard ratios for all-cause mortality were 3.57, 95% CI, 2.77 to 4.61, 9.88, 95% CI, 7.55 to 12.93, and 8.60, 95% CI, 7.15 to 10.35, for ischemic events, major bleeding, and hospitalization for HF, respectively, all p less than 0.001. Conclusions: hospitalization for HF has become both the most frequent and one of the most ominous events among patients with chronic coronary syndrome. Although less frequent, major bleeding is strongly associated with worse patient survival. Secondary prevention should not be limited to preventing ischemic events. Minimizing bleeding and preventing HF may be at least as important. Next, we will be discussing articles. American College of Cardiology. Coronary atherosclerotic plaque activity and risk of MI. Study questions. Is vessel-level coronary atherosclerotic plaque activity using coronary 18F sodium fluoride positron emission tomography, PET, associated with patient vessel-level myocardial infarction, MI? Methods. Pre-18 for prediction of recurrent events with 18F fluoride to identify ruptured and high-risk coronary artery plaques in patients with myocardial infarction is a prospective longitudinal cohort study conducted at 9 sites across Australia, England, Scotland, and the United States, enrolling patients aged greater than or equal to 50 years with recent type 1 MI and multivessel coronary artery disease, CAD, between September 2015 and February 2020. They report herein a secondary analysis of patients who, after intravenous administration of a target dose of 250 megabecquerels, 18F sodium fluoride, underwent attenuation correction computed tomography, CT, dual cardiac and respiratory gated PET of the thorax, and electrocardiogram-gated CT coronary arteriography, CTCA. Results. Increased 18F sodium fluoride uptake was found in 679 of 2,094 coronary arteries and 414 of 691 patients respectively. On CTCA, 2,094 analyzable coronary arteries were identified, of which 832, 40%, were and 1,262, 60%, were not treated with percutaneous coronary intervention at index MI. During a median of 4 years of follow-up, MI occurred in 24, 4%, vessels with increased coronary atherosclerotic plaque activity, and in 25, 2%, vessels without increased coronary atherosclerotic plaque activity. Hazard ratio, HR, 2.08, 95% confidence interval, CI, 1.16 to 3.72. P equals 0.013. This association was not demonstrable in those treated with coronary revascularization, HR, 1.02, 95% CI, 0.47 to 2.25, but was notable in untreated vessels, HR, 3.86, 95% CI, 1.63 to 9.10, P, for interaction, equals 0.024. Increased coronary atherosclerotic plaque activity in multiple coronary arteries was associated with heightened patient-level risk of cardiac death, or MI. HR, 2.43, 95% CI, 1.37 to 4.30. P equals 0.002. As well as first, HR, 2.19, 95% CI, 1.18 to 4.06. P equals 0.013, and total, HR, 2.50, 95%, 1.42 to 4.39, P equals 0.002, MES. Vessel-specific coronary atherosclerotic plaque activity was associated with MI within the same coronary artery territory, and increased coronary atherosclerotic plaque activity was predominantly seen in coronary arteries without residual obstructive lesions. Conclusions. In patients with recent MI and multivessel CAD, coronary atherosclerotic plaque activity prognosticates individual coronary arteries and patients at risk for MI. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Insufficient bone mineralization to sustain mechanical load of weight in obese boys, a cross-sectional study. Context. The increase in bone mineral content, BMC, and density, BMD, measured by dual energy X-ray absorptiometry, DXA, in obese children may not sustain the mechanical load associated with weight, and the factors influencing bone mineralization are not well known. Objective. We described bone mineralization in boys with overweight/obesity and leanness in relation to body composition. Methods. Cross-sectional study in the Pediatric Endocrinology Unit of Angers University Hospital with 249 overweight/obese boys, aged 8 to 18, who underwent DXA and insulin, testosterone, and IGF-1 measurements. Bone mineralization was compared with data from 301 lean boys of similar age and height, from N. Haynes 2011 to 2015, using the same DXA model. Path analyses were performed to evaluate factors associated with total body less head, TBLH, BMC. Results. The mean age and height adjusted difference in TBLH BMC between obese and lean boys was 241 plus or minus 20 grams/cm2. Each 1 kilogram/m2 increase in BMI was associated with plus 39, plus or minus 6 grams of TBLH BMC in lean subjects versus plus 25, plus or minus 3 grams in obese subjects, p less than 0.05. Each 1 kilogram/m2 increase in lean BMI, LBMI, was associated with plus 78, plus or minus 5 grams of TBLH BMC in lean and obese boys, and each 1 kilogram/m2 increase in fat mass index, FMI, was associated with a decrease of 9 plus or minus 3 grams of TBLH BMC. The TBLH BMC was directly positively influenced by LBMI, and indirectly and positively influenced by IGF-1, testosterone, and insulin, mediated through height and LBMI. FMI indirectly influenced TBLH-BMC, both positively through LBMI and negatively through its negative impact on IGF-1 and testosterone. Conclusion: the increase in bone mineralization in obese children does not adapt to the increase in body mass. Next, we will be discussing articles from Neurology. Distribution of silent cerebral infarcts in adults with sickle cell disease. Background and objectives. Previously, we demonstrated that 90% of infarcts in children with sickle cell anemia occur in the border zone regions of cerebral blood flow, CBF. We tested the hypothesis that adults with sickle cell disease, SCD, have silent cerebral infarcts, SCIs, in the border zone regions, with a secondary hypothesis that older age and traditional stroke risk factors would be associated with infarct occurrence in regions outside the border zones. Methods. Adults with SCD 18 to 50 years of age were enrolled in a cross-sectional study at 2 centers and completed a 3T brain MRI. Participants with a history of overt stroke were excluded. Infarct masks were manually delineated on T2 fluid attenuated inversion recovery MRI and registered to the Montreal Neurological Institute 152 Brain Atlas to generate an infarct heat map. Border zone regions between anterior, middle, and posterior cerebral arteries, ACA, MCA, and PCA, were quantified using the digital 3D brain MRI arterial territories atlas, and logistic regression was applied to identify relationships between infarct distribution, demographics, and stroke risk factors. Results. Of 113 participants with SCD, median age 26.1 years, interquartile range, IQR, 21.6 to 31.4 years, 51% male, 56, 49.6%, had SCIs. Participants had a median of 5.5 infarcts, IQR, 3.2 to 13.8. Analysis of infarct distribution showed that 350 of 644 infarcts, 54.3%, were in 4 border zones of CBF, and 294, 45.6%, were in non-border zone territories. More than 90% of infarcts were in 3 regions: the non-border zone ACA and MCA territories, and the ACA-MCA border zone. Logistic regression showed that older participants have an increased chance of infarcts in the MCA territory. Odds ratio, OR, 1.08, 95%, CI 1.03 to 1.13, P equals 0.001, and a decreased chance of infarcts in the ACA-MCA border zone, or 0.94, 95% CI 0.90 to 0.97, P less than 0.001. The presence of at least one stroke risk factor did not predict SCI location in any model. Discussion. When compared with children with SCD, in adults with SCD, older age is associated with expanded zones of tissue infarction that stretch beyond the traditional border zones of CBF, with more than 45% of infarcts in non-border zone regions. Next, we will be discussing articles from CHEST. Tolerability outcomes of American Thoracic Society / Infectious Diseases, Society of America Guideline, recommended multi-drug antibiotic treatment for Mycobacterium avium complex pulmonary disease in U.S. Medicare beneficiaries with bronchiectasis. Background. Non-tuberculous mycobacteria are environmental organisms that are increasingly causing chronic and debilitating pulmonary infections, of which Mycobacterium avium complex, MAC, is the most common pathogen. MAC pulmonary disease, MAC-PD, is often difficult to treat, often requiring long-term multi-drug antibiotic therapy. Research question. Is there an association between various guideline-based 3-drug therapy, GBT, regimens and 1. Therapy-associated adverse events, or 2. Regimen change/discontinuation within 12 months of therapy initiation? Study design and methods. In a retrospective cohort study, we examined tolerability outcomes of GBT regimens for MAC-PD in 4,626 U.S. Medicare beneficiaries with bronchiectasis who were prescribed a GBT as initial antibiotic treatment for presumed MAC-PD during 2006 to 2014. Using multivariable Cox proportional hazard regression, we estimated adjusted hazard ratios, Rs. Compare the risk of adverse events and regimen change/discontinuations within 12 months of therapy initiation in various GBT regimens. Results. The cohort had a mean age plus or minus SD of 77.9, plus or minus 6.1 years at treatment start, were mostly female, 77.7%, and were mostly non-Hispanic white, 87.2%. The risk of regimen change/discontinuation within 12 months of therapy was higher for clarithromycin-based regimens than azithromycin-based regimens, AHR, 1.12, 95% CI, 1.04 to 1.20 with rifampin, AHR, 1.11, 95% CI, 0.93 to 1.32, with rifabutin as the companion rifamycin. And for rifabutin-containing regimens than rifampin-containing regimens, HR, 1.49, 95% CI, 1.33 to 1.68, with azithromycin, AHR, 1.47, 95% CI, 1.27 to 1.70, with clarithromycin as the companion macrolide. The AHR comparing regimen change/discontinuation with clarithromycin ethambutol rifabutin and azithromycin ethambutol rifampin was 1.64, 95% CI, 1.43 to 1.64. Interpretation. Overall, an azithromycin-based regimen was less likely to be changed or discontinued than a clarithromycin-based regimen, and a rifampin-containing regimen was less likely to be changed or discontinued than a rifabutin-containing regimen within 12 months of therapy start. Our work provides a population-based assessment on the tolerability of multi-drug antibiotic regimens used for the treatment of MAC-PD. Prophylactic minocycline for delirium in critically ill patients. Background. Delirium is a potentially severe form of acute encephalopathy. Minocycline has neuroprotective effects in animal models of neurologic diseases. However, data from human studies remains scarce. Research question. Does the neuroprotective effect of minocycline prevent delirium occurrence in critically ill patients? Study design and methods. This study was a randomized, placebo-controlled, double-anonymized trial conducted in 4 ICUs. Patients aged 18 years or older were eligible and randomized to receive minocycline, 100 mg, twice daily, or placebo. The primary outcome was delirium incidence within 28 days, or before ICU discharge. Secondary outcomes included days in delirium during ICU stay, delirium/coma-free days, length of mechanical ventilation, ICU length of stay, ICU mortality, and hospital mortality. The kinetics of various inflammatory, IL-1 beta, IL-6, IL-10, and C-reactive protein, and brain-related biomarkers, brain-derived neurotrophic factor and S100B, were used as exploratory outcomes. Results. A total of 160 patients were randomized, but 1 patient in the placebo group died before treatment, thus the data from 159 patients were analyzed. Minocycline, N equals 84, placebo, N equals 75. After the COVID-19 pandemic, it was decided to stop patient inclusion early. There was a small but significant decrease in delirium incidence, 17 patients, 20% in the minocycline arm compared with 26 patients, 35% in the placebo arm, p equals 0.043. No other delirium-related outcomes were modified by minocycline treatment. Unexpectedly, there was a significant decrease in hospital mortality, 39% versus 23%, p equals 0.029. Among all analyzed biomarkers, only plasma levels of C-reactive protein decreased significantly after minocycline treatment. F equals 0.75, p equals 0.78 within time. F equals 4.09, p equals 0.045, group times time. Interpretation. Our findings in this rather small study signal a possible positive effect of minocycline on delirium incidence. Further studies are needed to confirm the benefits of this drug as a preventive measure in critically ill patients. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology. Sotagliflozin and kidney outcomes, kidney function, and albuminuria in type 2 diabetes and CKD, a secondary analysis of the SCORED trial. Background. In the initial analysis of the effect of sotagliflozin on cardiovascular and renal events in patients with type 2 diabetes and moderate renal impairment, who are at cardiovascular risk, SCORED trial, because of early trial termination and suspension of adjudication, reconciliation of EGFR laboratory data and case report forms had not been completed. This resulted in a small number of kidney composite events and a nominal effect of sotagliflozin versus placebo on this outcome. This exploratory analysis uses laboratory eGFR data, regardless of case report form completion. Assess the effects of sotagliflozin on the predefined kidney composite endpoint in the SCORED trial, and additional cardiorenal composite endpoints. Methods. SCORED was a multicenter, randomized trial, evaluating cardiorenal outcomes with sotagliflozin versus placebo in 10,584 patients with type 2 diabetes and CKD. This exploratory analysis used laboratory data to derive the EGFR components and case report form data for the non-laboratory defined components that together made up the kidney and cardiorenal composites. A.I.O was also assessed in this dataset. Results. Using laboratory data, 223 events were identified, and sotagliflozin reduced the risk of the composite of first event of sustained greater than or equal to 50% decline in EGFR. HeGFR, less than 15 milliliters per minute per 1.73 meters to dialysis or kidney transplant with 87 events, 1.6%, in the sotagliflozin group, and 136 events, 2.6%, in the placebo group. Hazard ratio, 95% confidence interval, 0.62, 0.48 to 0.82, p less than 0.001. Sotagliflozin reduced the risk of a cardiorenal composite endpoint defined as the above-mentioned composite plus cardiovascular or kidney death, with 239 events, 4.5%, in the sotagliflozin group, and 306 events, 5.7%, in the placebo group. Hazard ratio, 95% confidence interval, 0.77, 0.65 to 0.91, p equals 0.0023. The results were consistent when using different EGFR decline thresholds, and when only including kidney death and composites, all p less than 0.01. The incidence of A.I.O was similar between treatment groups. Conclusions. In this exploratory analysis, using the complete laboratory dataset, sotagliflozin reduced the risk of kidney and cardiorenal composite endpoints in patients with type 2 diabetes and CKD. Next, we will be discussing articles is from Kidney International Reports. Pregnancy and Family Planning in Women with Kidney Disease. Introduction. Females with kidney disease are at increased risk for pregnancy complications. Few studies have examined pregnancy perspectives of people with kidney disease. Our objective was to examine kidney patients' perspectives on family planning methods. We conducted an online survey of female patients with kidney disease from the University of Colorado Hospital between the ages of 18 and 50 years, from August to October 2022. The survey asked questions on previous and current pregnancies with kidney disease, family planning, and reproductive health discussions with their nephrologists. Perspectives on how kidney disease influences pregnancies were also explored. Results. A total of 136 participants completed the survey. The majority of participants were white, 71.3%, with a mean, SD, age of 37 plus or minus 10 years. The majority of participants self-characterized their kidney disease as moderate, N equals 57, 43.5%, with 16 participants, 12.2%, receiving dialysis. 52 participants, 38.5%, experienced a pregnancy with a diagnosis of kidney disease, which were largely planned, N equals 33, 61.1%. The majority of participants were able to conceive within 6 months, 64.8%. Nearly half of participants reported that kidney disease influenced their family planning decisions, with the majority, N equals 91, 66.5%, believing that kidney disease increased their risk for pregnancy complications. More than half of participants never discussed the health risks of a potential pregnancy, 54.0%, desire to have children, 58.0%, pregnancy prevention, 57.0%, and/or optimizing their health prior to pregnancy, 68.1%, with their nephrologist. Conclusion. Although kidney disease influenced family planning decisions, few participants had family planning discussions with their nephrologist.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.